We are live, please.
You can see it.
A very good evening, ladies and gentlemen. Welcome. Just a few days back, we had the grand installation of the Delhi chapter of ISM 6 under the guidance of our founder chairman, Dr. Amulya Sahu, and the core team of office bearers. The Delhi team is fortunate to have Professor Dr. Radhika Tandon and Professor Dr. Namrata Sharma as advisor patrons, led by our visionary chairman, Professor Dr. Rajesh Sinha, our dynamic president, Dr. Jatinder Bali, who is actually the brain behind this pertinent series, ever supportive Dr. Bhalla as the Vice President, and inspiring Dr. Anu Malik as the Secretary. I proudly welcome you to this very relevant first session of the series, Delhi Dialogues, Conversations that Shape the Future of Cataract Surgery. We will take up difficult situations during SICS and bring to you stalwarts who will enrich us with their tips and pearls on management. I request Dr. Bali now to kindly address the gathering and welcome the pillars of ISM 6. Sir, please.
Thank you, Dr. Richa. We've got a very energetic team, and one of the most energetic people is our moderator for the evening, Dr. Richa Gupta. And
Thank you, sir.
we are going to be presenting, people who are stalwarts, need not be advanced in age, but they are really advanced in skills. And I'm really fortunate to have, the founder chairman, Dr. Sahu sir, who has been a pillar of support and who is an inspiration because, when everybody was swimming one way, it was Sir, we would like you to address us, and then we will start with. We have two speakers for today. We have the dynamic Dr. Nilotparna Deori, who needs no introduction. East is synonymous with Dr. Deori, and at a very young age, she has been a trailblazer. And the second speaker for the evening is a trailblazer from none other than our own Apna Delhi. It is Professor Ankur Singh, one of the very dynamic people in Delhi, and watch out for these two names in days to come. Dr. Sahu, sir, please.
Well, I'm very happy that to see this young dynamic team led by none other than Bali, and so it's a young team and it's a bright team. And as you know, that this has become a very giant organization, a global organization, and we are all the time looking to spot talent and harness them. So, how to see? A lot of invitations are coming from abroad. We can I see I have stopped going to many places. So now Nilutpanna and also are going to Indonesia. Their invitation was there. Mexico, I refused. So I'm thinking all of you, once you get ready, it will be easier for us to send to different places and to represent India. So now we are having shortly a International Governing Council meeting on the 12th of August. So there I want to organize the same pattern as we have organized the India chapters. And they will be conducting, it will go in the ICO format. Okay, they should bid for the conference abroad. So it will take little time, but maybe 2-3 years to have a solid organization abroad. But we are going in the right way. My only focus is to see the talent and harness it. Thank you. Have a wonderful time.
So we also have with us Dr. Piyush Ramawat, who's heading the department in Lady Harding. And we have Dr. Shachi and Dr. Saloni. And somebody else has also joined. Who's joined just now?
Dr. Satanshu has joined, sir.
Welcome, Dr. Satanshu, sir. Finally, ईद का चांद जो है वो दिखे हमें आज. Welcome, sir. I think he's muted.
Yes.
Sir, with your permission, can we move to Dr. Nilotparna? She's talking about wound construction today, and nobody better than her to talk about the wound mechanics.
Nothing like that, but I'll try my best. So, should I start sharing the screen?
Dr. Richa, could we introduce Dr. Nilotparna, please?
Yeah, so Dr. Nilutparna Deori is a consultant, Pediatric and Neuro-Ophthalmology at Arbor Vitae. I hope I'm pronouncing it right.
Yes.
Eye Clinic Guwahati. Yeah. She has special interest in ocular genetics, but today she'll be talking on wound construction in SICS. Let's hear her.
Okay. Thank you so much. And at the very outset, I would like to thank Delhi ISMSICS Society for giving me this opportunity. And a big thank you to Dr. Bali also for his untiring efforts in bringing ISMSS together. So if my screen is visible, kindly let me
Yeah,
know.
it is visible. You can go full screen, ma'am.
Is it full screen now? Is it okay?
Yeah, it is full
Okay.
screen.
So, at the very outset, I would like to thank the ISMSICS Society, headed by Dr. Amulya Sahu sir, who has actually inculcated some amount of interest in me to go a little further in reducing the incision and also making certain innovations in the wound constructions. So this is basically a conversation where I will be speaking regarding the residents' way of handling their first cases and later on how they progress in their journey. And then finally, I will take up my topic. So how do you perfect your MSICS technique? I do not have any financial interest in this presentation. So we have all seen that throughout over the past decades, there has been a lot of changes in the tunnel construction. Specifically, it is either the incision that we are placing on the sclera or whether how we are handling the nucleus. So when we talk about the wound incision, it has started from the straight incision. You can go ahead with a frown incision. You can go ahead with the U incision, the Chevrolet, the 3 millimeter, the 2 millimeter, the back cuts, and so on and so forth. So, excuse me. So basically, we need to understand that whenever we are doing a sclerocorneal tunnel, it starts from the sclera. If you are going ahead with a straight incision, it can be 6 to 7 millimeter scleral incision, depending on the grade of the nucleus. And then it goes inside into the cornea around 1.5 millimeter, where it is parallel to the limbus. Now, these incisions, when when you make the sclerocorneal tunnel, they usually form a trapezoid shape. Now, the reason being, when we enter into the cornea, there is some amount of extension into the cornea on both sides. Why? Because the sclera is more elastic as compared to that of the cornea. So you cannot have like stretching on the cornea, because then the breakage point will be reached and you will have a very ragged wound and a lot of astigmatism later on. So in order to have a very smooth delivery of the nucleus, whether you bring it in toto or you bring it in half, or bisect, trisect, whichever way you want to do it, you should always aim for a little larger wound into the cornea and a smaller on the sclera. So this is just a textbook photograph of showing how the arrowheads showing the extension into the sclerocorneal, that is the limbus area. Now, in the first video, I am going to show you how we proceed. Once you have a good exposure of the superior area, so you go ahead either with the oblique incision with both the conjunctiva and the tenons held together. Then while you go in, make sure that the corneoscleral scissor actually both the blades go in, and then they separate the tenons from the sclera. Once this is completed, I think it's going quite fast. Once this is completed, we need to hold the tenons that is left on the either other side, and then make sure that you have a good exposure of the sclera where you want to place the incision. Now, whenever we cut the tenons, we have seen during our residency that we are a little apprehensive about entering into the tenon space. So what we do, we place our scissors little extent, and then we withdraw, and again we go in. That's not the way you should do it. You should go in, expand, and cut at one go if possible. And then you think of going ahead with the incision. So this, we are planning for a frown incision here. And when you plan for a frown incision, either you take a Bart Parker blade, and then it should be held perpendicular to the sclera, and the cut should be obliquely placed. The depth of the incision is usually 1/3 of the scleral thickness. And if you're using a crescent knife, the edge of the crescent knife is actually gives you a guide about how depth, at what depth you are going inside the sclerocornea. Now, if you look at this picture, I have stopped the video here. You see that we are holding the conjunctiva and the tenons on the last end or the trailing end of the peritomy. The reason being, whenever we are doing any incision, be it phaco, be it SICS, or be it any other surgery, pterygium, whatever surgery we are doing, whatever procedure we are going to do, the step that we are going to do should always be purposeful. The word is purposeful in a sense that you have already made a good exposure of your superior aspect of your conjunctiva and the sclera while making the incision. So it is not necessary that you keep on pulling the globe, holding the other parts of the conjunctiva, because the purpose of taking a crescent in your hand is to make a undermining of the incision that you have made. So you really want to go into the tunnel. Your purpose is not to injure or tear apart other parts of the conjunctiva. And holding the tenons will only give you a good grasp of the globe, and it will make the globe steady. And since it is an SICS under local anesthesia, your globe will not move much anyhow. So once you do this step, once you're at this step, 1 minute. So I'm going to stop here again. When you are entering into the cornea, up to the limbus, you have some amount of resistance. This is because that the scleral lamella is arranged in a different way as compared to that of the cornea, which is regularly spaced. So now what happens when we go in, the hand movement should be such that the tip should move according to the contour of the globe. So when we are in the sclerolimbal area, it is better to go in a wriggling movement, so you have a proper depth and you can see the translucency of the crescent. But when you enter inside the corneal substance, the moment you go in, you will feel that it goes in very smoothly, and you will really enter more than the length that you have expected. So when we go inside the cornea, your movement should not be wriggling movement, but it should be in a very smooth sliding fashion. So can you see? So there is some amount of tilt when you are going on either sides, but the tilt should not be such that you cut the roof of the cornea. Now, once you made the tunnel, we need to make sure, oh God, this video is running here and there. So we need to make sure that the keratome entry should follow the plane that we have made. Usually what happens when we try to go in, sometimes we go in a different plane, and ultimately we make a wound, a sclerocorneal tunnel, but then the entry wound is a different one. So follow the wound path, and if it is difficult, you can use also some viscoelastic substance to go in. So you see the sliding movement, and once the tip is visible in the cornea, so just dimple the cornea, but do not extend it more. As I have told you, because the cornea has a lamellar regular arrangement, your tip of the keratome will slide more into the substance of the cornea, and if you are expecting for a 1.5 millimeter entry into the cornea, you will end up in having almost 2 millimeter or 3 millimeter entry, increasing the length of the tunnel. So that is not what we expect. Now, since this is a frown incision, so here the pockets are more in an enlarged way, where the nucleus can easily sit when it comes out of the wound. Now, let me take you to the OR. Now, this is the resident. Now, they will perform the first surgery. Now, you see, as I have told you, if I stop the video here, you will understand there are many things going on here. One is how the globe is being held. She has held it here, but we would have preferred to her to hold in the trailing end of the tenons. Second is that the wound depth is okay, it is almost 1/3, and she has made a straight incision. So we are going for a straight scleral incision with an entry into the cornea in a similar conventional fashion. Now, as we will proceed into the surgery, you will see that the microscope is not focused on the wound, but the microscope is a little decentered. This usually happens when it is your first case, so that has to be considered. Now, so this is the undermining. And once they have undermined, this is the wriggling movement you do. And you will notice that once you have crossed the limbus, it goes very smoothly. So now, if it is a straight incision, then we will have to aim for a trapezoidal pocket on either side of the incision. So you need not go from either side, just continue with the continue from where you had started, either it's from the right side or from the left side, and complete the tunnel. So she's trying to make the pocket on the sclera and the cornea now. Okay. So this is done. Now you will see. So this is a very good tunnel for a first timer. Always make sure that you are actually watching or observing your incision properly. Now see, if the sliding movement is abundant in the beginning because they cannot see the plane, then you can either put some visco into the pocket and then go into sliding movement. Now you will see this, there is some resistance. Then the entry and the cut is done. Now what has happened here? What has happened here is the sclerocorneal tunnel was made up to here, but the entry was made here. The reason being that the flow of the tunnel, that is the entire floor or the roof of the tunnel where you should be in, was not achieved. This usually happens either because of apprehension or because it is a first time and we cannot make out the plane of the tunnel at certain points of time. So this is the first case. Now, as we move, the same person, as she has proceeded further into her surgeries, so a minimal cautery has been done for this case. And now, because she doesn't want to injure any other part of the conjunctiva, so she made a graded incision where she plans to hold the sclera. So she'll hold the sclera, and this is a crescent where it is graded and the depth is achieved easily. So this is another straight incision that has been made. So the depth has been determined, and now the undermining. So you see, over a period of time, once you keep on doing the surgeries, you tend to understand where you actually are going. Now, from the center, if you try to enter, she's trying to enter. Now you see, I will show you. Okay. So can you see there is some amount of folding here. So this is definitely going to go a little premature. Now, if you identify that, okay, we are a little premature, abandon that site and then move from another site. So that is the beauty of SICS, in that you do not lose your tunnel even if you have made some mistake in the beginning. Now she has done the undermining again, and now she realizes that no, this is the correct plane. So we go in. Now, can you see the translucency? This is more acceptable. So once you enter into this translucent area, she goes ahead of the resistance of the limbus, and now with a sliding movement or a movement in a gliding manner all across the tunnel, she will enter, she will complete the tunnel. So this she has completed. So throughout the procedure, you will see that no other areas of the conjunctiva or the tenons or any cornea has been um, damaged or destroyed. So once we attain a straight incision, a frown incision, you can then modify yourself into going either into the 3 millimeter or a 2 millimeter. Here I have shown you the pockets will be the same because because your incision is a frown shaped incision. So whether you will enter into the cornea in a 4 millimeter for a foldable IOL, or you want to go ahead with a 5 millimeter optic, you can go ahead with a 5 to 6 millimeter enlargement of the cornea. But this will not be a trapezoidal one because this is not a straight incision. So you have to have the back cuts behind. The elongation of the back cuts behind will depend upon the pocket size that you want to achieve, depending on the entry into the cornea. So here I have done my peritomy, bipolar cautery, and this is a frown incision, and then the back cuts has been given. So again, you will see that we hold it where the trailing end of the peritomy is done. So you enter here, same wriggling movement. So now, since you have to do the pockets behind, not further into the cornea first, so you will have to complete your pockets on either side. Now, there is one more thing that I want to point out here, that it is better when you are doing an SICS or any other surgery, just like even if you're doing a PK, if you are ambidextrous, and it will definitely come with time, you can really achieve a good entry pockets on both sides. So now here again you go in the sliding movement, but because this is a small incision, you have to enter obliquely. So you cut while coming out, and that's the end of your surgery. So during our residency, what we learn is what is the depth of the tunnel that has to be assessed, what the sizing of the rexis according to the nucleus grid, dialing the nucleus into the acid. These are the few important steps that we need to mind. As teachers or as mentors, we have to understand at which month should residents start training in SICS, how many practice cases in wet lab should they do, how many cases should they observe, when should a mentor take over a case from a trainee, how to mentally train a resident to not lose confidence after a complication, when should one analyze the complication, when is a trainee fit to start operating independently. Of all these aspects, one of the most important is whether their observation skill is good or not. So more important than the curriculum is the question of the methods of teaching, and it depends on every teacher, and also it is dependent on where they are doing. So there are places, or even you will get on, UC sites, we start in eggs, we start on tomatoes, we start on foil, and so on and so forth. Needle holding practices, both left and right hand ambidexterity, both foot movements, foot pedal movements are also very important. Using Kitaro kit is also quite helpful. And discussing the cases, discussing their complications, taking down notes is very pertinent. And even Dr. Henderson says that we have to be perseverant, disciplined, and open-minded in our approach, because sometimes you also learn from your students, and because every student is different, and they will only teach you that the holding method for all the students are different. So these are some of the self audits that we can do for your, can be individualized for each institution. And the scoring system can also be graded as such. For example, this is one of my students, just a peritomy or the tunnel that we say. Sometimes they have a very good peritomy and a tunnel. Sometimes they just drop down, and sometimes again they reach up and then plateau. The consistency is sometimes lost. And by looking at these 4 or 5 cases, and then we decide that what next, where do we actually intervene the student, which area is important. So these are some of the references. And I really thank ISMSS for giving me this opportunity, my clinic at Arbor Vitae, and my alma mater, Sri Shankardeva Netralaya, where I used to teach, and the students, my friends whose videos I have used, and my own videos. So thank you so much for your patient hearing.
Thank you, Dr. Dev. Extremely insightful, and truly appreciate the stepwise, presentation. I have one question. Do you still have ICO Oscar scoring? We used to use that in
Yeah,
our
yeah.
residency. For SICS and FACO, it's available right
Yes,
now.
yes.
Okay.
We do
But
that,
what you
but
showed was an indigenous scoring system, the paper
yeah,
that
yeah.
you showed right now.
Yeah, the one that I showed was something we prepared actually for our SICS students, and this was in collaboration with one of the photos that I showed you later, in my last slide with Dr. Manik. So we thought that we will modify. We modified. All of us have our own ways of teaching. You have your own student. You know what are their deficiencies, where they lack, how they hold, and all those. So you can make your individualized some steps. You can make your individualized way. And so this was something we did for ISMSICS. And if you wish to have it, we can really share that with you. So
That would be great, sir.
yeah,
She was in fact one of the first people who started talking of, rubrics for competency evaluation
yes,
in,
yeah,
in MSICS, be like something like the Oscars kind of a thing. Okay, so
yeah.
Dr. Nilotparna, if what would be your take-home message to the residents? Like, one, two, three, what are the top five things that they should be looking at
As I
when,
have told you,
when they start?
yeah. So as I have told you in one of my slides, that there are many things that you look for in a student, but observation skill is a must. You need to observe whether your student is really focusing on when you are doing the surgery, what the student is focusing, starting not only from the surgery, looking at the monitor or the side scope, but actually the way you are sitting, how you are handling the patient, how you are talking to the patient, whether even if the patient is moving the head, are you getting fidgety, are you getting angry? So my first introduction or initiation in the initiation class, I always tell my students that be it SICS, be it FICO or any other surgery, when you become an ophthalmologist, you are bound to do that. And that skill set you will definitely get through even if you do a multiple number of cases. But for a student, that period is also a period of character building. So that is how you make a rapport. That is how you make yourself individualized or a customized surgeon later on. So all of us are surgeons, but we all are excelling in our own way. So you would understand that
Very
everyone
well.
has a definite skill set, and as a teacher or a mentor, you have to identify in that student and then go ahead in polishing that skill set for the student. And even for the student also, that student, number one criteria or the quality of the student should be observation skill. You may not get many cases. Sometimes you get a lot of cases, but sometimes we learn almost 80% we learn from observation. So
So
maybe
basically,
from you, from Dr. Richa or Dr. Ankur or Dr. Neetu or whoever is here present today, everyone has a way of holding, everyone has a way of sitting, everyone has a way of doing. So they have to learn the best out of all of us. So that's how they will learn. And they have to adapt accordingly and then modify. So as I showed you in the videos, my student who started initially by holding at the trailing end of the peritomy, but then she was more comfortable holding tissue in the sclera by making a graded incision. So you have to appreciate that for her because she did not want to injure any other part now. So that's how the students also adapts according to their ability.
very well spoken. And talking
Yep.
of this, let me get in another great teacher. We have Dr. Sinha, who was down with fever. He's just
Okay.
joined. So, what would be your message to the students when they're doing their first case or this?
Bali,
Anji sir.
yeah, but see what in the yoga in the OT is happening. My book on Patanjali Yoga Sutra is now getting
Anji.
ready. It will be published in few in months' time. See, what we are doing there is samyam, that is the surgeon, the patient, your microscope, and you become one. And then samadhi happens. And the samadhi delivers you good. The more you meditative you are, the more successful you are. People don't understand. It is not a job or it is not a something to you are earning money. You are restoring sight. That philosophy should be deeply imbibed in the student. If the student is there only to get money, he is going to be a third-rate surgeon. There is no two way about it. So it's a yoga process. Now, with my book, you will bring yoga into every aspect of your life, and you will see that Patanjali is relevant to all aspects of our life, and that would be a good contribution I will be making. So when
So when
Niluspanna
is
was doing those things, na, observation is just one aspect of it. But you becoming samyam means you are becoming three into one. Just forget yourself. So that is how samadhi happens.
सर
So
वो कहते हैं ना आत्मसात करना. So what is important is not only cognitive, you have to internalize it and then you have to live it for it to become. So, sir,
yeah,
this is what
I,
I feel. They have
in the
they are
same lines,
embarking on a journey. Surgery is like a journey. So पहले दिन में if they are expecting that they are going to be, so it's going to be a slow process. It's going to be a slightly you'll fall. You don't have to lose your confidence when you fall, but eventually you will reach that place. So don't start evaluating yourself on the first day. And at the same time, the more you talk, the more you look at others having achieved it, see how they have done it. Probably that is everybody will have a different journey, sir.
yeah, actually, Dr. Bali, what Sahu sir was telling, actually, based on those lines only, I would also like to say that, what probably he meant, the initial part of that samadhi can be how much you are involved in the surgery. I mean, even somebody who is assisting you, there can be two different types of assistants. One who will just be sitting there and occasionally putting some saline over the cornea or something. And somebody who is totally involved, the moment finds anything abnormal, gives you the right instrument. So this means that he is into that kind of a samadhi or that kind of involvement. So I really liked what sir was telling. That was really fantastic. And I must congratulate you for starting this webinar under the guidance of Sau sir, and very fantastic. A very nice talk, Dr. Nilutparna. I just joined in a little late. My apologies for that. But I could see all those points, those minor points that you told, that, when there was a fold coming, then you asked the resident to start from the other side and all these things. I just want, from my own point of view, from my own curiosity, a lot of people are now trying temporal side, a lot of people are doing superior side. For a beginner, what do you advocate?
For a beginner, I would advocate a superior side because the first instance they sit on the microscope is usually the head end of the patient. So that is my suggestion. And once they get into doing the surgeries, they know even to understand the subject. Like even with block, without block, I have seen people advancing even into temporal SICS, uh, like from the uh, topical temporal SICS also. So it eventually it's a practice, but in the first instance, just to know about the technique itself, it is better to go from the superior end.
I agree.
I was yes, sir. Sir Sahu, sir, could we have your take on that?
Yeah, this is he has told the right things. He's a good teacher, and you cannot teach from temporal side for the beginner because the sclera is so thin there, and you have no way of holding it properly. Going away from the visual axis and making an incision, which will be it's not advised at all unless if somebody does hundreds of cases, and that too very good surgeries. They should not venture for temporal side. It gives less astigmatism, that's all right. But 12 o'clock position is the standard procedure. And it's people should start from there only. Earlier, they were giving this, superior rectus stitches. We don't advise that. It creates
Yeah.
more problem than solves. And
Yes. So we also do not advocate using superior rectus anymore. As I have told you, the word that I used was purposeful. Purposeful. That means the purpose of doing the surgery, maybe the incision or the peritomy, should be only peritomy, not doing anything else. Should be only doing incision, not anything else. Should be only doing a rexis, nothing else. It should be, every movement should be purposeful. So if the purpose of the superior rectus can be avoided, then it is better not to injure the superior rectus and just go ahead without doing the superior rectus.
The comfortable, they choose a comfortable thing. The surgeon should be confident that comfort will automatically come. If your surgeon is not is shaky, then this kind of comfort do not help.
And usually superior rectus brings the eye down, sir. So, and your surgery is not going to be in that depressed position.
Right.
You eventually have to bring the eye in the ortho position when you enter into the cornea. So, I
Actually, what happens is everybody's gotten used to that superior rectus suture. So the first time that you stop applying it is the time when you feel a little shaky. After 4 or 5 surgeries of without superior rectus suture, you realize that it was not even required. It's almost like the training wheels on your bicycle. So, that's like even I used to feel that how can we do without it? Then once we stopped using the superior rectus, that's when we realized it wasn't even required in the first place. Thank you so much,
So
Dr.
shall we
Nazarkar.
move ahead? Yes, yes, sir.
sorry.
And now,
Thank you so
now
much.
we,
Yeah.
so with your permission, we would like to move on to our second presentation for the day. Dr. Ankur happens to be a phaco trainer and a vitreoretina surgeon, and he's trained a lot of children in SICS as well as phaco. So he would be talking about the the PCR and the complications. And he always makes very lucid presentations. So the take home message here is basically how to react when you have a problem. Dr. Richard, if you could please introduce.
Yeah, so Dr. Ankur is Associate Professor, UCMC and GTB Hospital, Delhi, and he'll be talking on management of PCR and other complications. Over to you, Dr. Ankur.
A very good evening to all. Thank you, International Society of Manual Small Incision Cataract Surgery, Jitendra sir, Amulya sir, and Sinha sir for this wonderful opportunity, as well as for the nice introduction. So I'm going to talk about, just allow me to share my slides. So I'm going to talk about the PCR, a complication that doesn't happen in the hands of prominent surgeons like Sinha sir, Jitendra sir, Amulya sir, but it does happen in a lot of students or residents who are learning phacoemulsification or just started doing SICS. So this presentation is directed uh, more towards residents rather than the proficient surgeons who know how to tackle everything. So I'm going to talk about management of posterior capsular rupture and its complication in cataract surgery. So before we go into how to manage posterior capsular rent, we need to understand and identify the eyes at risk, which could be because of the patient factors or the surgical factors. If the patient already has pseudoexfoliation or ephicodonosis, you already know that the zonules are weak. And in these particular patients, it is very difficult to perform capsulorhexis, nuclear rotation. And during that thing, you can rather induce dialysis or PCR can also happen. If you are dealing with a brunescent, mature white cataract can have an Argentina flag sign, which can lead to a PCR. And at the same time, while doing phacoemulsification, because I'm going to dive over into the domain of phacoemulsification because the SICS and phacoemulsification are two cataract surgery the residents are very fond of doing now. There's going to be a talk which is going to mix between SICS and phacoemulsification. So when we are removing that hard fragment of the mature nucleus, these are the patients when those your sharp fragments can rip to the posterior capsule leading to PCR. Small pupil are difficult to handle from the beginning itself. You are not able to visualize. You are not able to prolapse the nucleus into the anterior chamber. At the same time, during phaco, you find it difficult to even chop and separate the two nuclear fragment. Weak granules I've already talked about. posterior polar cataracts have certain set of patients already have pre-existing posterior capsular dehiscence that can open up during the surgery. If there is a posterior vitrectomy in this patient, we need to understand the vitreous provides a scaffold, and it holds the posterior capsules when you're doing if SICS or phacoemulsification. And if there's a vitrectomy, there's nothing to hold the posterior capsule. So posterior capsule literally moves up and down if the anterior chamber is not stabilized well and can lead to PCR. And at the same time, poor fundal glow. Then you need to understand there are surgical factors that can lead to PCR. If you are having a difficult nuclear rotation, I would suggest doing another round of hydrodissection, because that can lead to PCR and as well as dialysis. If you put excessive posterior pressure during either the hydrodissection or during the phaco or during the SICS, it can lead to capsular rupture. And at the same time, if there is a weakness in the posterior capsule, it can give away. So one need to understand what happens. How do you recognize those signs of PCR? So it could lead to sudden deepening of the anterior chamber. So I request all the residents who are listening to it, remember these signs, because by the end of this talk, we're going to put up a video where we're going to discuss when did the PCR happen and how did you found that the PCR happened in that particular video. So there could be sudden deepening of the anterior chamber, sudden change in the red reflex. There could be pupillary snap sign, which is the enlarging of the pupil size during the PCR. If you're doing a phaco, there would be loss of nuclear flowability, nuclear fragment. If the PCR happens in the very initial stage, your nucleus will sink and it will tilt, and you will find suddenly the nucleus has tilted, and that is the sign that the PCR has happened. And if you're finding it difficult to maintain the occlusion in phacoemulsification, if there's peaking of the pupil, you may be able to visualize a vitreous trend coming in the very end of the phaco surgery or the SICS surgery. And if suddenly the last fragment disappears. So let's just discuss about phacoemulsification, because phacoemulsification, although a boon, but at the same time, this is a probe which is an ultrasound probe which is vibrating at a very high hertz. Suddenly, if it touches the posterior capsule, it can rip it apart. So if a PCR happens, what you need to do is cut off the ultrasound, cut off the aspiration, but please do not switch off the irrigation. So you shift from the position 3 to position 2. So what usually happens with the residents when they see a PCR, they get afraid and they shift to position 0. That is, they stop the phaco completely or they withdraw the phacoemulsification probe. This is what you should know. In SICS, if it happens, please do not worry. Just maintain just fill your anterior chamber with viscoelastic, which is obviously a dispersive viscoelastic. So how do we manage the first 30 seconds of a PCR happen? So it revolves around stopping, stabilizing, and assessing. So once you've stopped, you have to stabilize. And how do you stabilize? You stabilize the posterior capsular rent that has happened with the help of OVD. And what does OVD do? It acts as a plug. It is going to plug the posterior capsular rent, and this is not going to let the vitreous, which is going to have a positive pressure now, come into your anterior chamber or into the posterior chamber, into the capsular bag. So this is going to prevent this so that you can tackle anything which is left over here. And once that is done, then only you withdraw your phacoemulsification probe. Please do not do it before that. So once you have stabilized your eye, you need to assess. And you need to assess, is there any nuclear fragment in the bag? Has it gone down into the posterior segment? Are you able to visualize? Is it just near the PCR, or you are not able to visualize it? It has gone beyond your visual sight. You might also need to assess, is there any vitreous that has come in from if you're not able to plug it at the right time, it has come into the bag, and from the bag, from the posterior chamber into the anterior chamber into the wound. You need to look at this. At the same time, you also need to assess the size of the posterior capsular rent, because that is going to help you. Can you put the IOL in the tubular cavity which is left? That is, putting the IOL in the bag itself, If not in the bag, then in the sulcus, or you need to defer the IOL for a different kind of secondary IOL. If you have to assess that is there adequate anterior capsular support and there is a good sulcus there, so you can put a three-piece IOL over this continuous anterior capsular axis, the capsular margin beyond the anterior capsular axis, and you are able to, I'm going to talk about anterior posterior capsular axis because when I'm going to talk about capsular access, it means the normal capsular access that you do in your cases. But why am I referring it to anterior capsular access? Because in pediatric patients, in pediatric kids, when you're doing a phacoemulsification, you also perform a posterior capsular access. So when I'm talking about capsular access, from now on, this is going to be simple capsular access that you do in your phaco surgeries. So if you've done a good capsular access and you have a good capsular support, you can put a three-piece IOL. Also visualize if there's a D-shaped formation of the bag. If during the surgery, if the PCR happen and you see there is a certain D in the D-shaped formation in the bag, this is because of the journal loss. So try to assess the journals, because if you put an IOL in this is going to prolapse down into the posterior segment, or it is not going to center, or it is going to destabilize. So once you have spent the 30 seconds to stop, to stabilize, and to assess, you have four questions to answer. The four questions that you need to answer is the less material that has remained is cortex only? Is it epinucleus? Is it soft nucleus? Or is it hard nucleus? Has the vitreous prolapsed? Even if have you taken the right steps at the right time? If you have not, there is a vitreous prolapse? Is it at the level of pupil? Is it in the anterior chamber? Is it at the wound? And then you need to also see, which I have discussed before, what is your capsular access status? In white cataract, Argentina flag sign, your anterior capsule is gone, or you have inadvertently torn the anterior capsule, and you have damaged the capsular access which was existing before. So you need to see the status of the anterior capsule, and need to keep in your mind, is there adequate sulcus? At the same time, you also need to think that has the adequate chunk been taken care of? Has any part of the nuclear fragment prolapsed into the posterior segment or has dipped into this posterior segment? Is it significantly large? If significantly large, you need to think to stop the surgery, send it to refer it to the posterior segment surgeon. If it's very small, you can complete the case, put an IUL, take care of the chunk, and observe, which I'm going to discuss. What is the size that you can observe and where you have to do a vitrectomy? So if the PCR is there and the nuclear material which is there in soft, so although you have plugged the posterior capsule, sorry, you have already plugged the PCR with the visco-dispersive viscoelastic, you have to put more visco-dispersive viscoelastic. And what is going to do is going to move this nuclear fragment more superiorly. And at the same time, it is going to prevent any vitreous prolapse into the capsule. And there is when you can take care of this nuclear fragment with the help of your phacoemulsification probe. But always remember, reduce the irrigations, reduce the flow, and reduce the vacuum, and use minimal ultrasound. So when residents are doing a PCR happens, they get panicky. They just try to floor the phacoemulsification the foot pedal, and put as much as energy as possible just to take away that nuclear fragment. Because if you're going to do that, you are not going to only take away the nuclear fragment, you are going to take away a lot of vitreous, and that can lead to GRT intraoperatively. So be careful. So if it happens, reduce irrigation, reduce the flow rate, reduce the vacuum, use minimal ultrasound, and try to do this away from the rent that has happened, because inadvertently it can lead to your nuclear fragment or your capsular or nuclear fragment or your cortical fragment going into the vitreous cavity. And what you see over here, if there's the fragment is large and there's a hard nucleus, you need to change the plan. So if it has happened in SICS, you have a tunnel, you just open up that tunnel, use wire vectors, remove it as fast as possible. If you are doing a phacoemulsification, open up the cornea at the limbus with your scissors, or you can create again an SICS tunnel in a phaco case, and with the help of a Sinskey hook, where you see over here, you can literally withdraw those nuclear fragment with the help of Sinskey hook and a wire vectors. You can also put an IOL if there is a smaller chunk left, and the IOL can act as a scaffold. So once you have taken care of this nuclear fragment and you have stabilized the anterior chamber, remember how to deal with vitreous. So vitreous, one thing has to be remembered, never sweep the vitreous with the IA. So don't try to pull the vitreous with the IA, because this can lead to tearing of the retina at the retinal periphery, leading to GRT. It can lead to a lot of complications. So never pull the vitreous with the sponge or the forceps. Cut it. Vitreous, just cut it. Cut it with the help of the scissors. Now, if you're doing with the, if you have a phacoemulsification probe and you have a vitrectomy, that phacoemulsification machine will have a vitreous cutter. Use a cutter and cut before you aspirate. So what is that cut before you aspirate? Is a cut IA ball. So you have to bring down the vacuum, increase the cut rate to the maximum. So the amount of vitreous pull has to be very less, and the cut rate has to be very high. So you are just cutting the vitreous and aspirating the only the cut part of the vitreous rather than the formed vitreous. And always remember, don't go too deep with the cutters. You might inadvertently touch the retina with the cutters if you are not very well versed with the cutters. So just keep it over here. Just what you need to do is you have to debulk the vitreous which is over here, and you are trying to pull back the vitreous which has come into the anterior chamber, so that you can put an IOL, you can remove the vitreous from the wound. So you don't cut near the wound, you cut here. And what vacuum does is it pulls any vitreous which has prolapsed into the anterior chamber or the anterior segment. So what is important to understand is what has to be done is what I have taught you by now. But more than that, that is important is what not to be done. So do not fish posteriorly with a phaco tip, because phaco tip has a wide bore, and that wide bore is just going to take away the vitreous without allowing it to cut, and can lead to a lot of retinal complications. Don't use Sinskey or vectors into the vitreous. I said you can use the wire vectors in the anterior chamber when you stabilize the PCR. What I am saying is do not use the vectors inside the posterior segment or into the vitreous cavity. Irrigate, do not irrigate into the posterior segment. If you irrigate into the posterior segment, or you're going to put a lot of viscoelastic in the posterior segment, it is going to bring prolapse, it is going to prolapse more vitreous into the anterior chamber and out of the wound. And that's going to be a bigger problem for you, because this will leave your posterior segment filled with viscoelastic, and that is going to be a lot of problem with the in the form of raised IOP and a lot of inflammation in your postoperative period. And do not attempt blind retrieval. So if you are not able to visualize, don't just try to fish it, find it out. This is an eye. You have to be very careful when you are operating. Just do the minimal that is required and the minimal that you know. So when do you refer it to a posterior segment surgeon? So we need to understand that we need to refer these patients when the nuclear fragment that has prolapsed is very hard. It is leading to a lot of inflammation or IOP, which is difficult to be controlled medically. If the corneal edema is persisting, if there is an associated retinal pathology, and the fragment is unlikely to absorb. So I would simplify it for you. If you think you have taken care of all the nuclear fragments and you visualize the eye on the day one, if you can see any fragment in the eye with the help of an IOL, the patient has to be sent for vitrectomy. If you can see it, it has to be removed. It's as simple as that. That is what has to be done, because if you don't leave it, it is going to lead to chronic inflammation, and what it can lead to is an ERM formation. So how do you follow up these patients? You follow up with on day one with vision, which is going to be less. So you need to talk to the patient. You will expect a lot of corneal edema. The IOP might be high because of the viscoelastic, a lot of AC inflammation. You have to look at the pupil, the wound. You don't want to have a peaking on the postoperative day one, or you also want to look at the wound. Is there any vitreous in the wound? And look at the IL position, is it center or not. At 1 week, look at the IOP trend. Has the IOP stabilized? Is there inflammation on the reducing trend? Is there any lens material that has become flocculent is now in the anterior chamber as a pseudohypopion, or you are able to visualize any tag of cortex hanging onto your lenticular surface when you've dilated this patient? Look at the IL stability and look at the fundus. At the 4 to 6 week, do an OCT in this patient, look for any CME or the ERM that has formation. And in long term, please keep an eye, because whatever, if a PCR has happened, the chances of retinal detachment has gone up. So you need to be very careful with this patient. And the more time you spend over that eye, the more difficult surgery that has happened in that patient, the more chances of the patient having retinal detachment. Always tell your patient, if the patient develops flashes or new floaters, see curtain in the visual field, is there a sudden increase in the pain, suspecting endophthalmitis or sudden fall in the vision, he should come to you without failing. So this is the 7 mistakes that can happen, that can convert PCR into disaster. If you pull out the phaco immediately, if you continue using the normal fluidics, you don't reduce the, again, I'm saying you don't reduce you don't reduce the irrigation, you don't reduce the vacuum, you don't reduce the power. If you keep pulling the vitreous, if you start chasing about or for the drop nucleus into the vitreous cavity, you do an aggressive cortical cleanup, and you underestimate the retinal complication that can happen. So I would like to conclude that there's an algorithm that you should keep in mind while approaching a patient of a PCR or a postal capsule rent is stop the phaco, don't stop the aspiration. Don't stop the phaco and aspiration, don't stop the irrigation. Keep chamber formed, use dispersive OVD before withdrawing this instrument. Assess, look for the vitreous, use tricoat. If you're not able to visualize the vitreous, build a little bit of tricoat. I don't fill the anterior chamber with the tricoat. Look at the lens material that has remained. Is it anterior? Can you bring it up? Slow down the fluidics. If you are not able to take it out, don't worry. Just convert it into an ECC. Take it out with the from the corneal side, or take it out from the SICS tunnel. If lens has dropped, I mean to say the nucleus has dropped, do not chase it. Stabilize the eye and refer it to VR surgeon. If there's an adequate capsular support, go for a 3-piece IOL with an optic capture. If there's an inadequate sub support, you can plan a deferred secondary IOL in this patient. At the end of the surgery, always check for the pupil. Is it circular or not? Look for any vitreous in the wound, because if there's vitreous in the wound, this is a high risk for endophthalmitis. Close it securely. Suturing is no harm in patients when you have a PCR and there's a vitreous in the wound. You have done a vitrectomy. Suture the wound, be it SICS, be it phacoemulsification, and keep a an enhanced posterior post-operative surveillance in this patient. So whenever a PCR happens, I would just say be calm. Close the chamber, cut, do not pull, keep the nucleus anterior. Let the capsule choose the IOL. Don't choose the IOL. Let the capsule choose the IOL and respect the retina. Now look at this case. So what we have learned how to manage the PCR, I would request please be with me and look what are the faults that will happen in this case. So this is a case where the resident was performing, and this is a good case where the resident was performing a phaco and he has managed this case, but he has done some mistake. So look at this. This is the only the epinuclear plate that is left. He's trying to bring it up, take it out, and look here. So the moment he tries to just give me sorry for that. Uh, So the moment he tries to bring the large, you see those lines that are coming here. This is where the capsule has come in contact with the tip of the phaco and the PCR has happened. The resident has found something has happened in this case, but he's not sure. She or she is not sure. He continues the phaco. Then he sees the PCR, which is over here. The resident panics. He just removes all the instrument. He has not put the viscoelastic. Look, the size of the PCR is increasing. Now the resident realizes that I need to put viscoelastic. Now, if you have visualized, the the vitreous have already come through the wound. The more viscoelastic that you put is going to make the vitreous prolapse more, because he's using a cohesive viscoelastic in this patient. Now this resident is trying to take care of the leftover the cortex without realizing that the vitreous has already come into the wound. So he's using a lot of energy. He's trying to take out the cortical fragments, the epinuclear plate, the epinuclear plate, and doing that he's also pulling the vitreous. So here, if you see, with the help of the fake, there is a pull that is happening over here, but the resident is able to, take care of the most of the segment well. For him, he has done a good job. But then he puts a tricot and realized that there was a complete vitreous in AC. And you will see that the vitreous was already in the wound over here. Look at this. This is the vitreous which has been strained with tricot, and it was there in the wound since the beginning. So while trying to remove that fragment, there was constant pull at the vitreous. So that resident has performed the vitrectomy. That's good that he has done. He's taken care of the any amount of vitreous that is into the anterior chamber. Now the anterior chamber is little devoid of the vitreous. He has done a good IA. Could have used a cutter in place of using an IA, a circular pupil, and the wound is suture. So there's something that he has done rightly, something that should have been taken care of. If you would have put the viscoelastic before withdrawing the phacoemulsification, the posterior rent would not have enlarged and things would have been much better. Thank you.
Such a well-structured coverage, Dr. Ankur. And as you said correctly, it is important what not to do in such situations. Um, Dr. Sinha, are you there? Would you like to add something to this?
Yeah, actually, very nicely covered talk. Ankur, if you can just unshare this,
I'm just doing that.
yeah. So, very nicely covered. And one thing which I really appreciate, you have multiple times, emphasized that whenever there's a PCR, you should not take out the probe completely like that. Keep the irrigation on. From the side port, you take viscoelastic, go into anterior chamber, inject viscoelastic, inject dispersive viscoelastic here. Why? Because dispersive viscoelastic, say viscoat or any dispersive viscoelastic, that will cover the area of the break. Cohesive viscoelastic, what happens that it remains, in a cohesive manner, and it can go behind. So it's better to use a dispersive viscoelastic at that time, and then the probe can be taken out. And then, of course, what we can do is that if it's a small PCR, then one may think of rounding it off. If you can round it off, then like a posterior capsular axis, you can place an IOL in the bag. But if you're not able to round it off, then and it has become big, then there's only option left is multi-piece IOL in the sulcus. Now, if you are placing a multi-piece IOL in the sulcus, then it is always advisable to do an optic capture. And Dr. Ankur also had emphasized about that. Optic capture is essential because all these lenses are square edge designs. So the iris rubs along the edge of the IOL, and that causes pigment dispersion, and later on can have secondary glaucoma, etc. So if you do an optic capture, then the edge of the IOL will go behind, and it will not cause rubbing of the iris tissue. Then again, an important point is in such cases, we should not hydrate the wound when we are at the end of the procedure, because because it will again have a tendency, because once you have done a vitrectomy after putting tricot and ensured there's no tag in the vitreous, no vitreous tag in the anterior chamber, then it is advisable to put a suture rather than hydrating the wound to close the wound. And there's no harm in putting a suture in these cases. We should have no hesitation in that. Another important point will be that at the end of everything, I mean, once you have put the suture and everything, again, you should ensure by putting a few droplets of tricot, so that sometimes what happens that the last manipulation of even putting a suture, etc., can get some, vitreous, and there can be some strands. So it's better to, at the end of the procedure, after putting the suture, you have two side ports, put little bit of tricot and see that there's no vitreous. If there is any tag, then you can always take your cutter and then cut that tag, so that uh, at the end of it, the pupil should be round, and in the post-op period also, the pupil should be round, because it is not just a cosmetic thing that people should be round, but if there is any peaking, then there can be traction, risk of tear formation, risk of endophthalmitis. All these things are there. And and of course, risk of damage to corneal endothelium as well. So that is the thing. Mm, as far as the I will, if it's bad tear which has extended beyond I mean, sometimes in a posterior polar cataract or anything which extends beyond the equator, and your anterior capsule also very flimsy, or the anterior axis was not very regular. I think there's no harm in waiting and putting the IOL after some time, once the capsule becomes a bit fibrous and taut, if you're not sure that the capsule will maintain the IOL. And if there's any doubt and the patient cannot come, an old patient cannot come again, then even an anterior chamber IOL can be placed, but placed properly in a proper manner after doing a complete vitrectomy and a small PI, so that you have a good chamber depth. If the chamber is shallow, then it should be avoided, and one may think of doing either a iris claw lens or a SFIOL. So all these options are there.
Dr. Piyush, would you like to add something? Dr. Sinha, you've covered everything. There's probably only one thing we can talk or like we can think of. It's like the mechanics of the posterior, like rounding the posterior tier.
Yeah.
So in anterior, you want to deepen the chamber. When it is posterior, don't put too much visco. Let it come up a bit. When you put too much visco, then there is a tendency for it to run away. So if when you have when it is, because it is, the anatomy is concave, so
Yeah.
don't fill it too much, and try to round it if it is small. If it is big, then of course you don't have too much left.
Hearing is most controlled when the membrane is flat.
Exactly, exactly.
So, if and since, as you said, that the posterior capsule will have a tendency to become concave, so it's better not to inject too much of viscoelastic. Now, anterior capsule, when you're doing an anterior capsule axis, is a little elevated like this. So, if you inject a little bit more, then it will become flat, and then your control of the axis will be good. But for a posterior capsule axis, injection of viscoelastic should be less. It should not be overfilled.
So
Otherwise,
basically, the take home
problematic.
message is, before you come out, before you take the probe out, from the side port, your visco should be going in. That is a basic reflex that you should be able to develop, that your hand comes out, the chopper goes out, and you put the visco before you exit. And put the suture, whenever in doubt, put the suture. That is the most important thing in such cases.
Very true.
Uh, we also have Dr. Anu has joined. Dr. Piyush, do you have any comments on this? Dr. Piyush, Dr. Neetu, फिर हम सर के पास जा रहे हैं, साहू सर के पास.
Very nicely covered by Doctor. Both the talks were comprehensive, and all the things are very well covered. Only things regarding the second talk, rightly pointed out by Dr. Ankur, that we should differentiate between the zonular dialysis, zonular damage, and the PCR, because the management will be completely different for both the things. And so assessment is important. That 30 seconds are important, and the further decisions are depend on that.
Thank you, Dr. Piyush. Dr. Anu, anything to add? फिर हम सर के फाइनल कमेंट्स पे जा रहे हैं. I think we've lost her. Sahu sir, say
Yeah.
your comments.
I was hearing is, but they are competent people. The main thing is the panic should not be there. As they say that you mention maintain your calm and leave the rest to be done by the VR surgeon, because any jugglery there or any kind of acrobatics can create more problem than it solves. So that's the fundamental things. And if there is a teacher who is overlooking all these things, they, as it was told by Anup, that see them taking out the probe suddenly and all, it can make to collapse and vitreous, more vitreous collapse and all those things. Those are all practical points, and I think the guide can help the students. But basically, surgeons should never go into panic mode in any situation. The captain should always be on charge, come what may, and that gives that you are responsible. Many a time, so the surgeon's mentality has to be prepared. But you are the captain, and you can't allow the ship to sink. So that really empowers you mentally, and once you are mentally empowered, then you win. And difficulty will be there. That should be accepted. That no surgeon is can guarantee that nothing will happen. Only minimize the problems. That's all.
True, sir. The only surgeon who's never had complications is somebody who's not operating.
Bas. So is a surgeon material or not? That should be seen. Some wrong person should not be in the right place.
True, sir.
Hmm.
So thank you so much, sir. So with that, I think we come to the end of our webinar, and
But
I
it,
will.
it was a good interaction, good thing, and that should be see now from here onwards you formulate rules because you are capable of doing those things, guidelines, and for the training purpose and all sort of things. It will give you time to think. So those guidelines will circulate in all chapters. So
We will do
okay.
that. So we have Dr. Sinha with us. We have Dr. Sinha, we have Dr. Ankur, we have Dr. Piyush. Neetu is also a very active member. And Anu, of course, is bubbling with energy. So I think I'll call upon Dr. Sinha to please raise the vote of thanks. He wasn't well. I'm really thankful to him for having joined. Thank you so much, sir.
The biggest thanks goes to you, actually, Dr. Bali, because you have made so much of taken this initiative and made efforts to, plan this webinar. And obviously, as Sahu sir was telling, we have to formulate rules and we have to be consistent, and that I'm pretty sure you will be able to do that. Uh, then, of course, a big thanks to our two speakers, Dr. Nilutparna and Dr. Ankur, for excellent talks and pointing out some very relevant points, which I must tell you, it was a lot of learning for me as well. And it really, was fantastic. Both the talks were very good and some very nice, experience points that came from the experience from Sahu sir, and those things were really fantastic. Thanks to the
Richa
IT
was
team of
moderating, sir.
Sunil. Sorry.
Richa was moderating today, sir.
Yeah, yeah. So thanks to Dr. Richa. Richa has just now immediately she okay, we lost her. So a big thanks to Dr. Richa, Dr. Neetu, and Dr. Anu as well. And thanks to the IT team led by Sunil, and it has been supported by NTOD. So thanks to NTOD as well. So thank you very much, and very good night to all of you.
Good night. Thank you so much.
Bye.
Good night, Dr. Nilatparna. Good night, Sahu sir, Dr. Sinha, Dr.
Good night.
Ankur.
Good night to all of you.
Bye. Good